Coming to the therapy of hypertension in itself. Is monotherapy important? Yes, it's important. In how many percentage of patients? 30% only will be beneficial on monotherapy. The guidelines mention in monotherapy, you can give any one of the 5 classes: diuretics, calcium channel blockers, beta blockers, ACE inhibitors, or ARBs. You can initiate and maintain your blood pressure treatment on this idea. Taking in mind blood pressure, if you have your blood pressure from 140/90 till 159/99, this is considered mild hypertension. This patient has no target organ damage. He does not have left ventricular hypertrophy. He does not have albuminuria or insulin resistance or aortic dilatation. Therefore, you can give monotherapy. You follow up your patient 1 to 2 months and he comes back. He's on a good blood pressure, one of these monotherapy drugs, and his blood pressure is controlled to 130/80. You continue. But if the patient has higher blood pressure, therefore you have to go into combination therapy. So therefore, combination therapy is advised when you have blood pressure more than 160/100 or above, or severe hypertension, where his blood pressure is 180/110 or above, and these patients may have target organ damage. Therefore, combination therapy, moderate hypertension, severe hypertension, those with target organ damage. Also, if the patient was subjected to a previous TIA or stroke or heart failure, most probably he will require combination therapy. Why combination therapy in hypertension? Why should we give combination therapy? Of course, to reach your target. Number 2, to prevent or regress your target organ damage. And number 3, to decrease morbidity and mortality. Which combination is preferred? Any drugs given together? No. You give either an ACE inhibitor with diuretic or an ACE inhibitor with a calcium channel blocker. Or on the other hand, you give an ARB with a diuretic or an ARB with a calcium channel blocker. You can give, of course, a calcium channel blocker with a beta blocker, no problem. Why this combination? As I said at the beginning, the mechanism of essential hypertension was either hypervolemia, RAS activation, sympathetic overtone, or genetic. So here, if you're giving 2 drugs in 1 pill, therefore you are attacking 2 mechanisms. And this is very important in the control of blood pressure. Of course, we have many preparations of drugs now, dual therapy, and 2 drugs in 1 pill. And also we have triple drugs in 1 pill. So single blood pill administration is very important, especially in severe hypertension or patients with resistant hypertension. The question is, which combination is not preferred? And is this a general rule, or certain drugs are not to be given? Anyway, if we talk about beta blockers and diuretics, which we know they increase the uric acid and cause triglyceride disturbances and glucose intolerance, and they have minimal effect on LVH and albuminuria. Of course, we know that atenolol and propranolol were the commonly used beta blockers before in the last 30-40 years, and these 2 were specifically responsible for these metabolic disturbances which we find in combination therapy. But if we look at specific or selective beta-1 beta blockers, they have no effect on the metabolic profile. And this is very important when you give a selective beta blocker with a diuretic in a reasonable dose, 25 milligram, not more than 50 milligram hydrochlorothiazide, will not affect these metabolic parameters. Another combination which is not preferred is giving an ACE inhibitor with an ARB, because the 2 mechanisms, if you look at the 2 drugs, they are complementary. But when they used this combination in the on-target trial, they found out that hypotension, hyperkalemia, and renal disturbances were much more. So they mentioned in the guidelines where we should not advise an ACE inhibitor with an ARB, even in chronic kidney disease.